I will talk more specifically about spontaneous reporting. And just to put it in context, I have already talked about the experimental methods that we use to find out about drug-related risks. They are the animal experiments and the clinical trials. They are experimental because in clinical trials you can have a control group, you can have a placebo group. But once you have a drug on the market, you don't do experiments with patients. So then we can only observe. We observe what's happening to patients as they are taking our treatments, the ones that we are prescribing. And there are various ways of doing that. And epidemiological methods, then you look at populations. And it's debatable whether spontaneous reporting actually is an epidemiological method, because you actually look at individuals. You treat individuals and you look at what's happening to them individually. But we are doing that in the context of the population. And of course, the spontaneous reporting database become some kind of a reflection of what's happening in the population. So here we are dealing with case reports, and you should note this acronym, ICSR. It's one of these almost words that are creeping into our language. It stands for Individual Case Safety Report, and it's coming out of the ICH collaboration, International Conference on Harmonization. ICSR, okay? We used to call it an ADR report before, but now we are supposed to call it ICSR. And my previous boss, Ralph Edwards, he's arguing that this is completely wrong, because it's not a safety report, it's a harm report. It is. It's a report of harm, right? So it should be called an individual case harm report. But they prefer not to use that. Yeah. And you can do it, collect them individually, or you can have a series of such reports, and you identify them together. And then we have also methods looking at open cohorts. For example, we look at tuberculosis patients in a particular setting, in a particular hospital, and then you can do spontaneous reporting within that target cohort. We have something called cohort event monitoring, where you actively follow up normally some 10,000 people who are exposed to a particular medicine. You follow them up and see what happened to them. So that's a cohort event monitoring. It's an open cohort. We don't have a control for those. And then you can also do intensive hospital monitoring. You can follow all the patients who are coming into a particular ward, and you can record all the drugs they are prescribed and they are taking, and you can also record what's happening to them. And then we have the more standard epidemiological methods, controlled cohort studies, where you have one group of exposed people and then you have another group as similar as possible in all other respects, the difference being that they are not exposed. They are not exposed to the drug what you are studying. That's a classical control cohort studies. And then you have case control studies, where you start with the disease. You start with the phocomelia, and you say, what did all these people who had a malformed child, what were they exposed to? So you look back in time, and you have control babies, and say, what's the difference between those who got the disease and those who did not get the disease? So that's the case control study. And then you can also, these days, you have a lot of electronic health records, and you can also tie together the exposure data. In this country, we have almost all prescriptions on electronic records, and you can identify the individuals who have been prescribed certain medicines. And then we also have outcome registers from hospitals, and you can connect the exposure to the outcome. That's what we can do with record linkage. And then we also have the meta-analysis, which is just a way of increasing the power of the studies. You can do that for clinical trials, you can do it for cohort studies and so on. If the individual studies that you have are too small, you can't see whether it's a risk is happening in 1 in 5,000. Well, you bring several studies together and you treat them as one, and then you start calculating your statistics on the whole lot to increase the power. That's what meta-analysis is about. Okay, that's the kind of context where spontaneous reporting fits in. So what is, well, I have already explained what is spontaneous reporting about. It is about recording suspicions of undesirable events happening to patients while they are on treatment, and then sending in this suspicion to the pharmacovigilance center. And spontaneous reporting has a lot of advantages, and one advantage that I think is clear to you now when we have talked about the disadvantages of clinical trials is the size. In order to find the rare adverse reactions, we have to expose large amount of people, big populations. And that's what we are doing in spontaneous reporting, because we are basically collecting information from the whole population. So if we have a high reporting rate, we have a good means of getting information from the whole population. And if we are talking about India, then that means 1.2 billion people. If we are talking about the WHO program, potentially, how many are we? 5 billion in the world? 6, are we? So that's the benefit. You can actually, with this method, have the potential to find very rare adverse reactions that you can't find in any other method. And we can follow all medicines at the same time. We don't have to decide that we'll make a study on this particular drug that's now come onto the market. We follow them from day one to the time when they are disappearing from the market. And that's very important. The long perspective, the life cycle approach. There are many problems that we have found after a long period of time. Take Ray's syndrome with aspirin, for example. It was used almost for 100 years before we realized that if you take aspirin while your children have a viral disease, they have this increased risk of getting Ray's syndrome, which is a very serious disease. When we learned that and we started not using aspirin, Ray's disease almost disappeared. And we hadn't figured it out. Very complex, very rare, and it took a long time to figure out. And we can do spontaneous reporting wherever healthcare is offered. All healthcare facilities can be involved. We don't have to decide that this is done only in hospitals, only in general practice, or in public health programs. Everywhere we can do it. We can collect information, suspicions about drug-related effects. Another thing is that we can identify the people who have been affected. and we can try to find out what makes them different. Why is narcolepsy happening to these kids and not to all the others? And that's, of course, important to try to find out the mechanisms. Why does it happen? And that's how we learn about pharmacology and also about immunology and all those things. But perhaps the most important characteristic of spontaneous reporting, why it is the method of choice all around the world, is that you can do it without a lot of investment. Clinical trials are extremely expensive. The epidemiological methods are cumbersome. They are complicated. You have to have very proper knowledge of epidemiology to carry them out in a scientific way, and they take time. Cohort studies take time. Spontaneous reporting needs a reporting form, and it needs people who can really be passionate about telling their colleagues around in the country that you have to take part of this. You don't need a lot of investment in equipment. You can get started with very small means. That's why it's become the backbone of pharmacovigilance activities around the world. Spontaneous reporting, in spite of its strengths, does not solve all our problems. And I'm sure you're all aware that we have serious issues with underreporting. We don't get information about everything that we want to know about. And we are going to talk about that tomorrow. Why is that so, and how can we stimulate our colleagues to report more and better, more complete, and so on? It's a serious issue that we get such a tiny fraction of everything that's happening in healthcare system is being reported to us. In spite of legislation, in spite of nagging, in spite of all our missionary, it just doesn't happen. Even in countries where spontaneous reporting has been around for 30, 40 years, perhaps the overall reporting rate is some 5%. One problem is that we don't have a fixed underreporting. If we knew that it was always 5%, it would be fine. We could compensate for it. But that's not the case. We know that serious and severe reactions are reported to a higher extent than the more trivial ones, which, of course, is a good thing. I mean, those are the ones we are most concerned about. But we can't calculate incidence rates on the basis of spontaneous reporting. It also plays a role at the time from market introduction, and that's where this graph comes in. It's the so-called Weber curve, the Weber effect, which was first described by Peter Weber from UK, that you have a period after the market introduction of a new product where the reporting rate is high. It increases from the start of the introduction, the coming into the market, and then possibly for 2 years you have a high reporting rate, and then it falls off because health professionals say, well, now we know about this. We have reported it so many times. I'm not going to send in another report. So the reporting rate comes down. But we can influence it again if we are, say, finding an issue, we are warning about a particular problem with the medicine, then the reporting rate can come up again. See if I can go back. it also, I mean, reporting is influenced by many things, like what the pharmaceutical companies are saying. They are saying this new coxib, it's not causing any gastrointestinal bleeding, no gastrointestinal discomfort at all. You'll be fine. And then the patients are coming to the health professionals, say, oh, I really get a lot of heartburn and I really have serious problems with my stomach. Well, then you say, well, this is not what the company said. This was not supposed to happen. And then the likelihood of a report being filled in is higher. So it also is affected by a lot of those factors that we don't have any control over, like how many company representatives are out there meeting doctors. Because in many countries, it's the companies that are collecting the ADR information, like in the US. 90% of all the cases are coming through the companies. And those companies having more health, representatives seeing doctors will collect more data. So their products will look worse than those with few sales representatives. So again, it's very difficult to calculate risks on the basis of spontaneous reporting, because it's not a clear reflection of the actual risk. Promotion of the reporting system is a very important issue. If we sit in our offices and do not show what our program is achieving, why you need to keep on reporting, you will not get any reports. You have to be out there, you have to be showing your results and to show what you use the data for in order for the reporting to keep on going. So it's very much, you have to be in the public eye, you have to be working with media to be seen, otherwise you will not be successful. And then, of course, also publicity of a specific association. The media plays a big role. If there is an article in a big newspaper or a popular news journal about a patient who took one medicine and got, say, a terrible eye problem, well, you can bet on it that the next weeks you will have a peak of such reports coming into you. Because people will say, oh, I had a patient like that. Perhaps I should report it. This doesn't mean that the risk with that medicine has increased. It's a publication bias, right? So we have to understand limitations of the methodology in order to analyze our data correctly. And I'm saying etc. because there are many other factors that are affecting the reporting rates. Other, say, limitations with the methodology is that it's difficult to detect delayed reactions. It's much easier to see that you take the medicine, you get an anaphylactic reaction, you get a skin reaction, and okay, it's quite obvious. So the suspicion is there directly. But if it's something happening to your personality and you think, I've been on this drug now for a year, and I think I have difficulties in concentrating when I'm reading, or those kind of issues are very, very difficult to connect and to find out about. I have a story of a friend who took simvastatin for 20 years, and all of a sudden he got very weak, very tired, and he was diagnosed with anemia. And of course, because I'm working with things that I'm working with, I said, Are you taking any drugs? Yeah, I'm taking simvastatin, but I've done that for 20 years. And then I looked into literature, and there were a few reports showing that simvastatin could cause anemia. And I said, why don't you stop it for a while? And he did, and it improved, right? Most of the time you don't find those issues. 20 years, no, you don't suspect it. And reactions with a high background incidence, they are often called the type C. And the typical example here is rofecoxib, Vioxx. Okay? Where you have those exposed get a slightly higher risk of cardiovascular events. But of course you have lots of cardiovascular events in the background population happening all the time. And how should we identify that those who are taking this particular drug have a slightly higher risk? Almost impossible. Actually, we did have a signal of rofecoxib and cardiovascular events very early from the Netherlands. But there was no way of confirming it. You just can't in spontaneous reporting. Yes? It's a question about this type C. Type A, type B, and type C are different kinds of mechanisms. Type A are the dose-related pharmacological effects. Type B are the hypersensitivity effects. Most of the time they are immunological. And then the type C is defined by the fact that you have a slightly higher risk while exposed. But it's a kind of chronic effects. I think it's there in one of the background papers. Other problems when spontaneous reporting is that details, important details, are often missing. And of course, a very important one is that we don't know how many have been exposed. So we cannot calculate incidence rates. Even if we have, say, 20 reports, 30 reports, out of how many? Well, we just don't know. If we are lucky, we are in a country or in a setting where we can have some idea of sales, how much have been sold in this population, and then we can get a rough estimate of exposure. But most of the time, we don't. And I've said it's affected by a lot of bias. So, here we go, Amr. What to report? Well, we normally recommend, if you're setting up a new system and you're about to create a reporting culture, you should have a very simple method, or simple message. And you say, report as soon as you see a suspected adverse reaction. Report everything. Because if you come and say, we want to know this, but not this and this and this, it becomes very messy and very complicated. But then you say, you can't be serious. I mean, I see adverse reactions all the time. All these skin reactions to antibiotics and all that. But Ralph Edwards used to say, report everything that concerns you. Something like unexpectedly serious or unexpectedly severe. Something which is a little bit different than what you're used to. Report at least that. And, of course, speed is essential. We don't want suspicions to be lying in people's head or reports to be in drawers. We want them in our databases so we can analyze it quickly if we are to be serious about prevention, we have to have the information quickly, right? Alternative approach. If you already have some reporting culture in your country and people understand that, yes, this is something we need to do, you often say, well, we want serious reactions to all medicines. And definitions of serious, that's available. Okay? Unexpected reactions that are not in the product information. I know that many countries don't have accepted SPCs or labels, or so that's in some countries a bit tricky. What is unexpected? Unusually severe reactions, and to new medicines, everything. Okay? This is a very common message in Europe or US, Australia, New Zealand. This kind of reporting recommendations. Here we go. Report type A, type B, the pharmacological, dose-related, not dose-related, unexpected lack of effects, as I said before the break, substandard and counterfeiting resistance interactions manifest itself in this way. Quality problems, dependence and abuse, medication errors, poisoning, possibly. Yes? Why not include all the other mechanisms of reactions? I would say that those authors using up to type F are not mainstream. What really plays a part in clinical practice are these, I would say, A, B, and C. The rest, I would say, it's academic. It's of academic interest. And it just makes it complicated when you're are trying to explain adverse reactions to your colleagues. Could we take this, because this is slightly outside of the scope of this presentation, and I think most of us are not aware of the various mechanisms up to F. So I think we'll have to take that a little bit later, hopefully tomorrow. And of course we want to have reports not only of, say, the normal medicines, so-called allopathic medicines, prescription, OTC. We want information about traditional medicines, biologicals, vaccines, blood products, and so on. And then some countries have also, say, expanded into medical devices, cosmetics, veterinary medicines, depending on your legislation and what your country needs. For us, we are not in these areas. So we are not including these areas and these product categories in our teaching. Who should report? Well, there are various ways of approaching it. And you can ask all these health professionals to report, but you can also, if you feel that it would be too much, you can't cope with the data from all these categories, you can start with one and then expand. Physicians have been involved in spontaneous reporting from the very beginning, from the 60s. Traditional therapists, nurses are getting involved, pharmacists in most countries except for this country. Dentists, public health program managers, manufacturers, patients, caretakers are now getting into the pictures in the big way. And I think there are major benefits of doing that. But we'll talk about that a little bit more tomorrow. I'm very much aware that we are towards the end of this presentation. I just want to give you a few words about where to report. The information always starts with the patient. The patient is the one who's feeling the adverse reaction, the problem. And normally reports that problem to a health professional. And then depending on where that health professional is working, if it's in a hospital, you might report that to the Drug and Therapeutics Committee. They want to know and need to know what's going on in their hospital. It might be reported to a regional center, if your country has a regional center, and then to a national center. But in some countries you don't have, if you have a health professional who is a GP or is not in a hospital setting, you will be reporting to the regional center or to the national center. Or you can also be reporting to the manufacturer. And in some countries there is a legal requirement for manufacturers to submit information to the national center. But sometimes you get the impression that they are the originators of data, but they are not. They cannot create data. It's coming from here, right? And this is to show that the more steps on the way, the more you can gain in analysis and facts and judgment in each step, possibly. But there is always the risk of losing data. The health professional might not want to send on a report. The hospital Drug and Therapeutics Committee might not want to send on a report what's happening in their hospital. And it's normally a delay in the process. And one way of dealing with that is to introduce patient reporting, direct patient reporting, where you bypass those obstacles and you get information directly from the origin. And that's what we are developing now, and we are seeing a lot of benefits of doing that. These are the countries accepting direct patient reporting. At least there are many more. So that was it.